Don't miss that!
Welcome to Don't Miss That Radiology. Let's learn how to read an abdominal CT. Today's episode ties together several concepts we've already learned. Reading the scout image like an abdominal radiograph, and then Hartman's 6 patterns of tubular structures. We'll also review windowing and Hounsfield units. Today we're going to read an abdominal CT exactly the way I do it in clinical practice. This patient actually has an important abnormality, but we're not going to jump straight to it. Instead, we're going to use a systematic approach and see if we can find it together. So let's start how I always start, with the scout radiograph. So before anyone gets a CT scan, they get in the scanner and they sort of take a overview, and you get a lot of information from this. So the first thing I see is one arm is down. That's always interesting because we try to have the arms up so there is less stuff for the x-ray beams to go through. Realize that a CT scan is the same, using the same x-rays as a regular radiograph. That is not necessarily intuitive to everyone. Sometimes I'll get some visiting medicine residents or OB-GYNs, and that sort of comes as a shock to some of them. Just realize we're using the same types of x-rays to go through the patient, and we'll get sort of the scout first. And I'm going to use my mnemonic: stones, bones, mass, and gas. Stones, anything radiopaque. I don't see any kidney stones. Bones look okay. No mass or mass effect. I'm going to tell you, sometimes you get more information from the scout for the bowel gas than you do the actual CT scan. I think it's sometimes easier to see a small bowel obstruction on the scout than the actual images. And for me, I see the stomach here, I see some small bowel in the middle, some large bowel. That looks pretty good all the way to the end. They're not obstructed. So let us now look at the CT images. Now, I've touched on this on some of the initial podcasts and videos about Hounsfield units. So the x-ray beams are going around the patient 360 degrees and hitting the detector. And we can quantitate how bright something is or how dark using Hounsfield units. And hopefully you can see this. I have my cursor out here in the air. It is negative 1,000 Hounsfield units. The bone will be close to 1,000. Okay, and water will be 0. Fat, this patient doesn't have much fat, will be negative 100. So those are some of the basics. And we can also window. Wow, what did I do there? It looked like magic. I go back. All I'm doing is changing my grayscale. We have a great TikTok about this, but we'll be looking at different windows throughout the study. So let's get started. I always do a once-over. I like to come down and look at the whole image, and I'm looking for free air, free fluid, see if anything jumps out at me. And coming into the pelvis, I see a little bit of free fluid, which in a male patient is abnormal. So that sort of tees us off that there might be something abnormal. So let us, maybe you saw the finding, maybe you didn't, but we'll have a couple of opportunities to look for it. So let's start at the top. I'm going to switch to lung windows, and we're looking at the lung bases. Those look clear to me. Maybe a little bit of atelectasis there. We'll keep coming down. Now, this is a great look for free air. We had a special video about how to look for free air on radiographs, and we said a lot of burps and farts, air rises. So if I'm looking for free air, I'm looking up here, but all the air looks like it's in the bowel, so that's pretty good so far. Again, there's our free fluid. I'm not seeing any free air. That's good. So now we'll go organ by organ, and we'll start with the liver. And first thing I look at is morphology. Is it cirrhotic or not? Then density. Is it low density, like steatosis? Now this looks just perfect. Usually the liver is about 100 Hounsfield units. And realize it depends on the phase of contrast. I'm going to tell you we gave contrast. How do I know that? Well, here's my aorta, and the aorta is 100 Hounsfield units. If it were straight blood, it would just be 40 Hounsfield units. Now, you might be saying, hey, it's not that bright. Well, you're actually right. If it were arterial phase, it would probably be 300, 400 Hounsfield units. But what we did was we gave the contrast and we waited 60 seconds. This is the portal venous phase. And you note there's the portal vein going to the liver. That's nice and opacified. And we'll talk about that. All this is repetition. We'll keep repeating this. Let me know if you like this format, but I'll talk about different things on the different episodes. But this first one, we'll just get some of the basics. So just realize this was with contrast, portal venous phase, liver looks okay, portal vein looks great. And then I will look at the gallbladder, no calcified gallstones, no biliary dilatation. I did a TikTok. If you're seeing the bile ducts, they're dilated. So the fact I'm not seeing the bile ducts, that's a really good sign. Okay, so we will follow our portal vein there. And we said the portal vein is made up of the splenic vein. So there's our spleen there. The splenic vein runs across, and we're getting a free look at the pancreas. Note there's a splenic vein. The pancreas is right in front of it. So that's good. Pancreas looks good. And then it joins the SMV right there. So we have SMA, SMV. So that all looks pretty good. So realizing that, we got the liver, we got the pancreas, we got the spleen. Maybe the spleen's a little bit big, 14 centimeters. We'll give them a little bit of splenomegaly. So then we'll keep coming, we'll come back up. There's our stomach. So again, spleen, stomach, liver. So this is an important space here, the gastrohepatic ligament. Sometimes you can get lymph nodes or fluid in there, but that looks pretty good. Stomach can be hard to evaluate on CT. It's not well distended, but it's looking pretty good. There's our distal esophagus, maybe a little bit thickened. Is that esophagitis? Is it under distension? Hard to tell, but we'll follow the stomach into the duodenum. And then there's our duodenum. And this is a very important landmark. So we sort of touched on this already. This is the aorta. And then coming off the aorta are two vessels. We'll have the celiac axis first, and then the SMA. And there are going to be two structures that go between the aorta and SMA. One is the left renal vein, and the other one was our duodenum. So we had followed the stomach to the duodenum. I'm always making sure that the duodenum crosses the ligament of Treitz. There's no malrotation. But when I'm coming up, I'm looking at that left renal vein, I'm like, hey, that's a little bit funny. Maybe you guys saw this, maybe you didn't. And we're going to have a couple chances to make this finding if you do use my approach. But we have the left renal vein here. I'm going to tell you it's a little bit dilated. There it is going between the aorta and SMA. And hey, there's something in that left renal vein that's dark. What could that something be? Well, let's use our Hounsfield units. And we get about 40 or 50. What did we say is 40 or 50 Hounsfield units? Well, that's blood. And you can see the contrast-enhanced blood in the left renal vein is a lot brighter than this blood. This is thrombus. This patient has a left renal vein thrombosis. And you're like, wow, that's pretty impressive. Well, we got it because we were systematic. And we're going to have one more checkpoint, even if we missed it there. But I'm always looking for that duodenum, that left renal vein crossing, and then, the vessels here, aorta, IVC, so big red, big blue, portal vein there. So let's keep looking at the organs. So there's the adrenals, adrenal, and then we'll have our kidneys. And I always like to look at the kidneys on the coronal. And I like to say, if I can say, that the kidneys enhance symmetrically or asymmetrically. And if they're enhancing asymmetrically, it could be a problem with blood flow in, blood flow out, or urine out. Now, even though and you see the thrombus real nicely there, even though we have the left renal vein thrombus, both kidneys are still enhancing symmetrically. So it's not occlusive at this point. So that's good, but we need to identify it and tell the clinical team, which they did, and they actually ended up doing a thrombectomy, and the patient did well. So we are looking for anything in the kidney. So I always look at the enhancement pattern first. They're enhancing symmetrically. Is there hydros? I should not see the collecting system that well. If I'm seeing it, I need to think, hey, maybe there's hydronephrosis or extrarenal pelvis, something like that. But these collecting systems are good. Then we look for any renal lesion. There's a dark spot there. How dark? Well, we'll use Hounsfield units. And we get 6. So if we remember that water is 0 Hounsfield units and this thing's 6 Hounsfield units, that's really helpful because we just diagnosed a renal cyst. That's going to be a do not touch lesion. Okay, so we cleared the upper abdomen and we made the finding of the left renal vein thrombus. That's good. And we just go into the pelvis. So fortunately we already saw the free fluid, and that sort of tipped us off that something might be wrong. So we'll just check that free fluid again. If you can see that, it's 1 Hounsfield unit. So that's simple fluid. So that's good that we identified that. There's our bladder. I like to look at the bladder. On the sagittal, I'm looking for thickening. So we've diagnosed lots of cystitis, especially in females. That's an easy thing to miss if you're not looking for it, but this is the male patient, so we're not really expecting it, but you never know. So we're going to come from below, so there's the rectum, lots of stool, common sigmoid, and we're just working our way backwards. So there's the splenic flexure, there's our sort of big spleen, transverse colon, hepatic flexure, coming down to the cecum. There's a little bit of free fluid. Do we see the appendix? I think that little tubular thing right there is going to be the appendix. Sometimes I'll triangulate it. Sometimes it's easier on the coronal, like I think it is here. That little tubular thing coming off is going to be the appendix. We'll have a whole episode about finding the appendix, but right there, you're just looking for that little tail sometimes. But if you triangulate it, it's a lot easier. So this large bowel looks good, moderate amount of stool. I always comment on the stool. Sometimes the patient will have liquid stool, and that can be your clue that there's diarrhea, infectious colitis. Sometimes there's too much stool, constipation, and sometimes the stool can be fatty and can indicate steatorrhea, which you can sometimes see with malabsorption type of things if the patient has chronic pancreatitis or biliary problems. So lots of information in the stool, in the urine. That's why doctors are always asking about that in the ER. So we cleared that. That's great. This is a male patient, so we don't have to worry about the female reproductive tract. As you know, we'll take a look at the prostate gland, sort of unremarkable, and looking at the sub-Q tissues. And then we're going to come back up, and I'm going to, I actually use a template, which is really helpful. So, if I forget one of the organs, like, hey, I forgot to look for lymph nodes, hey, that's on my checklist. So I think it's important to have checklists. So we will look for lymph nodes and retroperitoneum. So we'll start in the inguinal regions, a couple of shoddy lymph nodes coming up the iliac chains. And then we should only have 2 dots coming up, big red and big blue. This is a common place for adenopathy. If you have additional dots here, that could be para-aortic adenopathy. And I see a couple of small ones, and I find it's helpful just to scroll back and forth, looking for those lymph nodes. And this is one of the hardest things for med students and beginning residents, I think, is to find those lymph nodes. But realize we get another check as we're coming up. I'm going to double check the aorta, IVC, SMA ratio, and then there again is that left renal vein thrombus. So in my retroperitoneum checklist, this is something else I got another chance to make the finding of the left renal vein thrombus. And sometimes you'll have the nutcracker phenomenon. The aorta SMA distance is narrowed, and the stuff will be backing up in the left renal vein. So that's a good thing to be looking for. And then just one last check coming up, looking for any adenopathy. And then we'll put it on bone windows. And you can see now the bones, we get, we're the window where we get good gray differentiation between the cortex and medulla. I'm looking for fractures. I'm looking for lytic lesions, blastic lesions. Coming up. Looking good. And then we'll look at the sagittal. One view is no view. Let me see if I can scroll around. So I really like the sagittal for the most information. So I do the ABCs for the spine. A, alignment, looks pretty good. So anterior, posterior, spinal lamellar lines. I look at the bones themselves. Are there fractures? Are there lesions? C, cartilage, looking at the disc spaces. Maybe there's a disc bulge. And then S, soft tissues. We will not forget to look at the soft tissues. And hey, maybe there's a little anasarca. Maybe it's related to the kidney with the left renal vein thrombus. My first question is going to be, hey, does this patient have nephrotic syndrome? Why does someone get a spontaneous renal vein thrombus? So we'll talk about that in a follow-up episode, but be thinking about that. And that's going to be my impression. This is going to get a phone call. This is an unexpected finding, and realize communication with radiology is extremely, extremely important. Of course, we're going to have our report. We want to answer the question. We want to be succinct. But if there's an important, unexpected finding, it's important to call the clinician and discuss it and document it. So hopefully this was helpful. There was one great finding on here. We found it several times using our checklist. And I think that's one of the learning points here is be systematic, look at the scout, check all the organs, and just be ready to learn. Do an abdominal CT. You really have to do a bunch of these before you get comfortable, but knowing what to look for, that's the first thing. So I hope you're enjoying these podcasts and videos, and let me know if you have any ideas for any other ones and if you like this format. Thanks for listening to the Don't Miss That Radiology podcast. I'm Dr. Matthew Hartman. Remember, you only see what you know. Keep learning and don't miss that.